All right, so good morning, everyone. My case is titled Neurons versus Nephrons, and we are going to be talking about vessel imaging and severe carotid stenosis. Our case is a 76-year-old gentleman that came in with past medical history of coronary artery disease, has known bilateral carotid stenosis, right more than left, had a left MCA ischemic stroke in 2019 due to paroxysmal AFib, and he's on anticoagulation adherent to his therapy, presented with a 3-day history of aphasia, right-sided weakness, and falls without injury at home. He was out of the window for thrombolytics, so endovascular therapy, and his brain MRI showed this punctate infarct on the left hemisphere, predominantly in the frontal and parietal lobes. His admission data was only pertinent for that creatinine of 1.7. His baseline is 1.5 to 1.8. And there was already data in the chart about prior vessel imaging indicating the right more than left carotid stenosis. But as you can see here, the carotid ultrasound was at 50% on the left and 30% on the CTA. So a little disagreement there, but not significant enough to do anything about it at that time. So his big known risk factors so far, looking at his case, are the AFib, the bilateral carotid stenosis, and the prior stroke. All his other workup was unremarkable at this time. So the question became, even 2 years prior, having re-imaged his vessels, did we really need to re-image his vessels? And we'll kind of see if we did or not. At Duke, we're very fortunate. We have multiple modalities we can use: ultrasound, MRA, CTA, and a catheter angiogram. So in discussing this, our team chose to, even though we could have done, he had an MRI and we could have done an MRA time of flight, it was already done, and we didn't want to send him back to the MRI machine for this. So the choice went with carotid ultrasound. It's low cost, it's accessible through our neurovascular lab. And the results were that his left ICA was not visualized. There was a lot of shadowing from calcified plaques throughout, but his waveform on the ultrasound was very consistent with an ICA occlusion. So the question was, well, do we stop here and say, well, his carotid is occluded and there's really nothing surgical intervention-wise that we could do? After a lot of debate in team rounds, we decided that a second modality was warranted, given that they didn't actually visualize the vessel. So we did a CTA head and neck, and the whole debate was all related to his creatinine. Just because his creatinine was not completely normal, the question was, did we want to put him through contrast? His CTA showed about 90% stenosis bilaterally. But then radiology did make the comment that they thought we should do an ultrasound, which we had already done. So kind of put a wrench in the mix there. So then we asked our neurosurgery colleagues to weigh in, and they wanted to do a catheter angiogram, which they did. And the right was about 60%, and the left was greater than 90%. So at this point, it's important to note that 2 years earlier, he had just been 30%. So, and his risk factors are very well controlled based on his admission data. So hard to know that, or hard to believe that in 2 years, he had progressed that left carotid stenosis so much that it became 90% from 30%. And rather, maybe there was a misread of that initially. So back to our brain MRI, and the question was, this patient ended up with 3 modalities to check this carotid stenosis. Did he need all 3, or could we have done a better job of triaging and figuring out which one we should have gone with in the beginning? When you look at his brain MRI, he has this stroke morphology that is very indicative of watershed infarcts, what we sometimes you might see referred to as a string of pearls. That is all within that ACA, MCA, and ACA, PCA watershed areas. So could we have triaged and maybe just went with the CTA to begin with instead of carotid ultrasound? And possibly, yes, we could have. So eventually the patient get a left carotid stent with neurosurgery. And the question might come up of why he ended up with a stent instead of a CEA. I put an arrow on his catheterangiogram pictures there that showed that severe carotid stenosis. The angle of that jaw is usually the cutoff for when they can do CEA, because that means that the plaque is a little bit above where they can get it all with the CEA. So that's why he ended up with the stent. And even after 2 contrast boluses, his creatinine only peaked at 2 and actually trended down by the time he was discharged, and he went to rehab with the modified ranking score of 3. So the question, back to our question, neurons or nephrons. I'm sorry, I don't have a definitive answer, but it depends. Being a clinician in stroke, my default answer would probably be neurons, but in reality, it really depends on the clinical picture and what options you have. So take-home points are, calcification is a challenge in vessel imaging interpretation. We need to be able to pick a study that gives us the best data for what we're looking for, but has the least risk for the patient and is also cost effective. So there are multiple things to look at. And then radiology reports are not always perfect. Clinicians are at an advantage because we have clinical data, and we need to be able to combine the two and also always personally review your own imaging. And then nephrons are resilient. You get a CTA if you need to get a CTA, if you need that data. But then you have to really think hard about any creatinine above 2.5 and really discuss with the patient risk versus benefit. And for carotid ultrasound reports that are limited, where the occlusion is not definitively seen, you need another modality to confirm that. These are my references, and these are my kids. Thank you.
Thank you, Mary. All right, so to introduce today's Grand Round speaker, I'm going to turn it over to Chris.
Thanks, Rich. So this week, we're going to be hearing from one of our soon-to-be graduating chief residents, Petra Brayo. Petra, if you guys don't know, came to us from Philly, where she did her undergraduate at Temple University, followed by a master's in urban bioethics. She then went to medical school at Lewis Katz School of Medicine, also at Temple, and then here has been a great resident. So I was kind of thinking yesterday when I was in her last chief clinic with her that I think one of her first inpatient rotations was with me, and it was probably one of the busiest weeks of general that I've ever been the attending for. And I think both of us were slightly overwhelmed and ready to pull our hair out. I'm sure she remembers me kind of not knowing exactly what to do that week. But I like to contrast that with yesterday, where basically for her very last chief clinic, I sat with my feet up on the desk and really, I don't think, budged all afternoon. So I think when she heads off to Georgetown to do her neuroimmunology fellowship, she's going to be representing us very well. So Petra, I'm going to hand it over to you.
Everyone, I'm just sharing my screen. Okay, I think it's okay. So my topic would be on the neurologic complications of cancer immunotherapies, or how I thought about them for the last couple of years as, here's a treatment that can save your life, but it comes at a heavy price. So disclosures, I don't have any. I just have a quick disclaimer though, that I'm by no means an expert on this. The topic of this grad round came from the fact that as a med student, I've never even know that immune checkpoint inhibitors existed or CAR T existed. And the first time I encountered that really was as a resident on the neurology consult service, where I'm called and being told to come and evaluate a patient on the oncology team who got pembrolizumab, and I was asked to evaluate for neurotoxicities. And I had no idea what pembro is. I had no idea what to evaluate even for. I talked to some of my attendings, and so, it'd be great if we can have a grand rounds on this, but yes, it never happened. So I decided just to teach myself about it and just share this knowledge with people here today. So my objectives really are just to talk about immune checkpoint inhibitors and their multiple neurotoxicities and how to treat them, and then switch gears to CAR T and talk about its specific neurotoxicity, which is known commonly as ICANS, and again, how to manage these patients. Kind of overview of our talk. I'll just start talking about how do we evaluate neurologic adverse events in patients who have received any cancer treatment. I'm going to talk a little bit about what has been traditionally thought as a neurotoxicity of the old drugs, the traditional drugs. And then kind of, like I said, shift gears to immune checkpoint inhibitors. We'll talk about some of the peripheral nervous system neurotoxicities, and then some of the central nervous system neurotoxicities, and then focus mostly on the neurotoxicity related with CAR-T. So these drugs are pretty much like here to stay. There have been a lot of improvement in patient outcomes with these two modalities, immune checkpoint inhibitors or CAR-T. Essentially, they are a last resort for these patients who have these malignancies, and they have been incredible. So I think even though they have a lot of adverse events related to them, it's sometimes like the patient's last hope, really. So when we're being asked to come in as a consultant or neurologist to evaluate for any adverse event related to a chemotherapeutic agent, I think we have to keep in mind that if you're saying that this is a side effect or an adverse event related to the chemotherapy that the patient received, that this is really a diagnosis of exclusion. And we have to keep in mind certain things. So the neuropathies associated with a lot of these agents, is it really due to the agent, or are we unmasking a long-standing neuropathy related to diabetes or alcohol use or other causes that are traditionally associated with neuropathy? Same thing, like when we were being asked to evaluate for a CNS neurotoxicity, is the encephalopathy and delirium that we're seeing in these patients really related to a adverse event happening, or are we just seeing some of the metabolic and infectious side effects of these agents? These patients are just very sick, they're prone to infection, they're prone to a lot of metabolic derangement. This is something that we can have in mind. And new brain mets are a possibility. I mean, these patients can get imaged in January, and by April, they have new brain mets. And same thing with leptomeningeal disease, any lesions to the spinal cord, the plexus, or the peripheral nerves, or even the epidural space. So I think part of any workup should include an MRI, PET, or even an LP to rule out some of these things, because we definitely say, okay, this is the chemo agent that the patient received. Because then that would change like how the patient is being treated for the cancer. And same thing, like paraneoplastic syndromes are something that we need to keep in mind. In really rare cases, the cancer immunotherapies that I will be discussing can trigger antibodies associated with paraneoplastic syndromes, but paraneoplastic syndromes in and of themselves can just happen with any malignancy. And we just need to know what we're treating. So to talk a little bit first about the old drugs, and traditionally, these have been associated with like peripheral nervous system side effects. Peripheral neuropathy is the most common complication of all of these. About 30 to 40% of patients will get it. And it has been associated with the old school drugs, the platinum-based compounds like cisplatin, the antitubulins like the taxanes and the vinca alkaloids, the proteasome inhibitors, and the angiogenic agents. All of these can give patients peripheral neuropathy. But the hallmark of this peripheral neuropathy is that it is dose and duration dependent. So tends to develop within the first 2 months of the treatment. As long as the patient is receiving chemo, it's going to get worse. And then as soon as you stop the treatment, in theory, this should improve. How long it takes to improve, again, depends on the dose and the duration. They have been associated to some extent, and some agents specifically, with this coasting phenomena, where things worsen a little bit after you stop the chemotherapy. But again, it should, in theory, improve down the line. And like I mentioned initially, if the patient is already predisposed to a condition that can make their neuropathy worse, like diabetes, smoking, they're not clearing the drug that quickly, or have any hereditary neuropathy, of course, they're going to get a worse neuropathy when they get traditional chemotherapy. And then if they get multiple drugs, like if they get a cisplatin followed by vincristine, well, they're going to have a compounding reason to have neuropathy. And most of these patients really have a sensory neuropathy. It's kind of like that stocking glove sensation. It's very painful. They have a lot of numbness and tingling. You shouldn't really see much like motor effects there, or affecting the cranial nerves, or any autonomic neuropathies with these drugs. And each of these drugs, like knowing what drug the patient received, it tends to have a specific association with it. So some of them you would know, oh, it affects like these sensory fibers more than anything else, or the ones that can cause some motor issues, you would know which one. So it should be very easy to figure out once you rolled out all of the other things I mentioned, if it's really related to this or not. But these traditional chemotherapies too can have some degree of CNS neurotoxicity. However, I don't think it's as severe as the immunotherapies that I'll mention later. So some of these CNS neurotoxicities can just result from direct damage. So a lot of these agents can affect the vascular structure of the brain, the white matter, and again, it's dose and duration dependent. And then the CNS neurotoxicities too related with this is kind of related to the kind of sequela of the immunosuppression that you're giving the patient. So if they have meningitis, PML, if they have coagulopathies that lead to ischemia, this is all necessarily not related to the cancer treatment itself, but it's just the immunosuppression that these treatments are aiming to get at. And headaches are very common with these patients. And again, if you're giving the drug intrathecally, like intrathecal methotrexate, you're going to see more CNS neurotoxicity. Not a lot of these drugs, however, do not have like the greatest blood-brain barrier penetration, so you should not really suspect them. Some of them are associated with stress, some of them are associated with seizure, but those are, again, the ones that really stand out and it's kind of very known like what they are. But there's this phenomena of chemo brain that some of the patients would have after receiving a lot of chemotherapeutic agents, that they're just foggy, they're not responding, they're great, and it's kind of this chronic encephalopathy leading into dementia. The biggest one that would have brain changes is the leukoencephalopathy associated with methotrexate. So kind of with this framework in mind of how this old drugs used to act, we'll kind of switch gears now to some of the new therapies that I wanted to focus my talk on. So starting with immune checkpoint inhibitor therapy. So what are those? They're simply monoclonal antibodies that are directed specifically at cytotoxic T lymphocytes. They're directed essentially with affecting how the immune system kind of have these stops. And if you do not let the immune system have all of these stops, then our immune cells can go ahead and attack the cancer. There are different types of them. So the first ones are ipilimumab, which is against cytotoxic T lymphocyte associated protein 4. PD-1 inhibitors are they are pembrolizumab, nivolumab. I'm probably not going to say these correctly. And then there are ones with this kind of similar protein, which is programmed death ligand 1. So those are the ones that mentioned are on the market right now. So when you give the patients these monoclonal antibodies, they are present and they kind of work on these activated immune cells that kind of maintain the self-tolerance. If you take this away, like I said, which is the body, then body's own immune cells can go ahead and attack the cancer cells. But with that in mind too, you're kind of can create a lot of like autoimmune toxicities, mostly because the own body, as long as they're attacking cancer cells, they can also attack good cells. The worst side effects are usually associated if you combine two categories of these checkpoint inhibitors. So if you combine a PD-1 agent and a CTLA-4 agent, you are more likely to have at least 30 to 50% of these patients having a neurologic adverse event, compared to 10 to 20% if you just give them one of those agents. But with that in mind, the neurologic adverse events are generally very rare. So very severe events are 1 to 3%. And these are often seen with combination therapy. So kind of, if I was a cancer patient and I'm being told, I have like really bad malignant lung cancer, and if they tell me, hey, there's 1 to 3% chance that you can get a rare neurologic side effect, and it's kind of very rare, it's a very severe one, but it has a very, very high likelihood of inducing remission, I think the bets are probably I will take that drug. The neurologic events that have been reported, they're essentially can start anywhere from the kind of beginning day one of treatment all the way until after discontinuation. So I think we just have to have a very high suspicion for them because they just can happen at any time. The typical period, though, that they tend to peak is days to weeks after initiation. And these neurologic events are frequently associated with events affecting other organ, which is often a flu. So again, besides like neuro kind of immune-mediated events, you can have like thyroid immune-mediated events, like other body organs can get affected too, and they tend to run together. So that should pique your suspicion that this is what we're dealing with. And for all of them, the treatment is usually it's going to be holding that immune checkpoint inhibitor followed by steroids. And I think that's the tricky part about it, because once you start down the route of steroids and even IVIG and Plex, essentially you took out the antibody that is supposed to kind of reprogram your own body to attack the cancer cells. You're essentially negating the effect of the cancer immune therapies. So I think it's not like something that you should go ahead and give kind of at the first suspicion that there's a neurotoxicity happening, because it's kind of figuring out like, is it really that severe enough, or can the patient ride it? And the most important things is a lot of the management that kind of been established, it's not necessarily based on any prospective trial to see what is the best thing to do for these patients. I think we just took kind of our, essentially what we do for any immune-mediated events arsenal of like corticosteroids, IVIG, Plex, rituximab, and just assume that it's going to work exactly the same. So with that, I would just like to start the case kind of to put put things into like how would we expect these patients to present if we're being called to consult to evaluate for this neurotoxicity. So our first case is the case of Mr. Y. So he's a 72-year-old guy, has wildly metastatic melanoma with brain mets. And for that, after going through all of the traditional chemotherapy, the decision was made to start him on combination ipilimumab and nivolumab, which is usually what is common for these patients. So 2 weeks after receiving his first dose, he started having some right-sided facial weakness. And kind of going through our mindset of like, let's make sure this is not related to the typical neurotoxicity. Let's just make sure nothing else is happening. He got a brain MRI that showed some stable left frontal brain mets. So nothing new essentially on the brain. And when we evaluated the patient, the pattern of his weakness was consistent with a lower motor neuron pattern, more than a central pattern. And eventually, we said probably Bell's palsy. Let's just give it a couple of days. But then 4 days later, that facial weakness started to become worse. And that at that time, he also reported some back pain and difficulty with climbing stairs. And exam at that time showed that he's having a really dense right lower motor neuron facial palsy, and then some mild ophthalmoparesis resulting in horizontal diplopia. His lower bilateral lower extremities were kind of weak. Right is slightly worse than the left. He had decreased sensation in his legs up to his knees in all modalities, and essentially had absent deep tendon reflexes throughout. His workup did an LP just to see kind of is there like leptomeningeal disease, what's going on, and he had some mild protein elevation 68 and some mild phagocytosis 41. He ended up getting just giving the peripheral pattern of things, nerve conduction study, an EMG that showed he had a moderately severe demyelinating polyneuropathy. That would be a typical patient that would be called to evaluate for immune checkpoint or inhibitor neurotoxicity. So to talk about what to expect with these patients. So most common thing that we see with these patients is neuropathies, but we can have very severe neuropathies and they can be serious or even fatal. Cases have been described. This can develop very soon after treatment initiation, as soon as the first 3 cycles. So for this patient, he started having symptoms within the first 4 days. And then the presentation can be anywhere from just a painful small fiber neuropathy to a more typical kind of immune-mediated phenomena, kind of like AIDP, and sometimes these can even progress to CIDP. And then in the cases of either AIDP or CIDP, the CSF can often show some phagocytosis, which is not the typical thing that you would expect just with run-of-the-mill AIDP that has the typical albumin-cytologic dissociation. Cranial nerve involvement, again, is very, very common with these patients. So it's not going to be kind of, again, the typical AIDP where we'll just see more like axial involvement. A lot of the times these patients can have facial weakness and ophthalmoplegia. And then the EMG does not help much because it can either show demyelinating or an axonal pattern. So it does not get you one way or the other, but tells you that there's a problem. And to make things a little bit more confusing, if you image these patients' spine or the brain, if there's a cranial nerve involvement, you can see some leptomeningeal enhancement, which is often kind of normal or expected with these patients, which makes it a little bit hard because then is this really like leptomeningeal disease or not? But I think a lot of it just comes down to like the timing of how these events happen and how they progress, and kind of combining all the data that you get together. Like I said, the management is typically when things, if things are in the small fiber neuropathy, kind of painful and annoying phase, we might not necessarily stop the immune checkpoint inhibitor. But if the patient is essentially bedridden and having a lot of cranial nerve issues, the treatment is to discontinue the immune checkpoint inhibitor, start steroids. And then if the steroids are not working, there's just a very low threshold to start IVIG or flex. And for a lot of these patients, they're often a very prolonged steroid taper afterwards, like at least 6 weeks, because this immune checkpoint inhibitor antibodies can have a very long half-life. And even sometimes the flex can take the night. It's still, some of them might still hang around. And some of these patients actually might end up having to get on rituximab or other agents because it just gets really difficult to control what they have, especially if they progress to CIDP. So it's kind of, that case of Mr. Y essentially fell into this like AIDP presentation. But they can also have other neuropathies. So again, they tend to typically occur early in the treatment course, but can start even months after the immune checkpoint inhibitor and can persist a little bit after discontinuation. And kind of a note that I read in one of the papers where they said, they looked at like if the patient received traditional therapies in the past, or they had a baseline neuropathy, like kind of what we talked about, the diabetes, the alcohol-induced neuropathy. It is really unclear how much you get like a compounding effect with these immune checkpoint inhibitor neuropathies. It doesn't seem to be quite a complete of an association, like the traditional therapies making the baseline neuropathies worse. If the patients get small fiber neuropathies, they can be very, very painful, and that painful aspect of it can be very tough to control. They can also have kind of these isolated cranial mononeuropathies, which can be confusing and sometimes difficult to essentially correlate if the patient just happens to have just a Bell's palsy. Like, is it just incidental or is it related to the immune checkpoint inhibitor? And then they can, sometimes to confuse things a little bit more, they can be acute or subacute, and sometimes not even a length-dependent presentation. So I read like one case where the presentation was kind of more of like a mononeuritis multiplex, and they attributed to immune checkpoint inhibitor, but this is not necessarily like a pattern that we would think of, and no one knows why it can be random at times. Out of all of the immune checkpoint inhibitors, the anti-PD-1 therapies has been associated specifically with a vasculitic type neuropathy. And this can present as a rapidly progressive symmetric lower limb weakness or an asymmetric mononeuritis multiplex, kind of like what I talked about. And then there's some other cases of sensory mononeuropathy with inflammation of the dorsal root ganglion that have been reported. And again, kind of said the management really is hold the agent, start steroids, and kind of consider working a lot on neuropathic pain agents. But from the report that I said, some of the typical things that we use, like the gabapentin, pregabalin, the TCAs, duloxetine, sometimes they're really not that effective. The one that I think was interesting for me to learn about is the myositis and the myopathies associated with these agents. So they are often associated, again, with the anti-PD-1 or anti-PD-L1 immune checkpoint inhibitors, and they tend to occur really early in treatment. These presentations typically start with this myalgia, which is often a kind of early warning symptom that something worse and bad is going to come. This myalgia kind of progresses relatively quickly to moderate and severe muscle pain. Then the patients start having kind of this mixed axial and limb girdle weakness, it can be followed really quickly with some difficulty speaking or swallowing, and kind of more of these bulbar symptoms, which shows as an ocular weakness, which is not what you would think of just a myositis. Like the bulbar presentation is really uncommon, and it's kind of unique to the immune checkpoint inhibitors, which in a way, this can be confused with myasthenia gravis because we tend to think of that more as an oculobulbar presentation. And to make things a little bit more confusing, they can happen simultaneously together. So sometimes tough to tell, is it just a myositis or is it a myositis myasthenia gravis combo? And then myocarditis can also be present. I actually saw a patient recently on consults who had just started with just isolated myocarditis, and that's how it began, which is a little bit rare for the myocarditis to be the first presentation associated with kind of this combo of myositis, myasthenia, and myocarditis. But yes, anything can happen with these drugs. And because of that, there's a recommendation that if you ever evaluate a patient with an immune checkpoint inhibitor on board, and we have some evidence of a myositis, they should have a cardiac evaluation, even if they're asymptomatic with an EKG and just troponins, because that myocarditis can start really quickly and the patients can deteriorate fast. To kind of differentiate the myositis from the myasthenia, really, you're going to have more of an elevated CK and aldolase and more of a myopathic pattern of EMG. Anti-striational antibodies kind of may be present with these myositis, and this is often associated with the more severe necrotizing form. If these patients are biopsied, they often show kind of a multifocal necrotic myofibers and endomysial inflammation consisting of CD68 cells and CD8 T lymphocytes. And these patients, unfortunately, are often very refractory to immunotherapy, especially the ones who progress within a couple of days. Treatments that have been tried besides steroids and the typical IVIG flex included Tacro, cyclosporin, but these are kind of very limited case reports, and these patients often don't end up doing well. I mentioned kind of myasthenia and diseases of the neuromuscular junction. This usually starts happening within the first 3 months of treatment, an average of 6 weeks after initiating the immune checkpoint inhibitor. From kind of a review that I read, they estimated the incident about 0.12% in a patient treated with nivolumab specifically. And in another study I read, it's more associated with melanoma being the kind of cancer that's being treated. It often has the classical myasthenia presentation of ptosis, diplopia, muscle weakness, dyspnea, dysphagia. And a lot of these patients end up having anti-acetylcholine receptor antibodies, but that is not typically expected. Some patients are just seronegative. And it's a little bit confusing, but I read a couple of reports that said that these patients, you can put them through an MG and they can have a normal rep stim, they can have a normal single fiber, despite very severe symptoms, which I just find really interesting. But again, immune checkpoint inhibitors are a little bit weird. Management, again, you just discontinue the ICI. You can just think symptomatically like Mestinon, and then they actually recommended high dose steroids for these patient group, which is not something that we would typically do for our myasthenia patients coming in for flares, starting the 1 gram of steroids daily initially. But I think in the case of ICI, some of the reports I read, they think that these patients improved with the high dose steroids. And again, IVIG and flex, like I said, when cases get very severe, a lot of these treatments are ineffective. And unfortunately, this is the kind of the leading cause cause of death related to immune checkpoint inhibitors. There's a 30% mortality rate related to myasthenia gravis in these patients. And these patients, up to 42% of them can often end up needing respiratory support and intubation and being in an ICU setting. So myasthenia in these patients can be really bad news. Other things that are associated with immune checkpoint inhibitors. So septic meningitis has been reported in some cases. This has been attributed really to maybe these activated immune cells and the cytokines are better able to cross the blood-brain barrier than your typical therapies. And headaches can be seen in these patients in the setting of this septic meningitis, or sometimes it's the hypophysitis that can happen. Unlike the PD-1 agents, the CTLA-4 agents are the ones that really are that good at crossing the blood-brain barrier and causing this septic meningitis. And it can happen with either monotherapy with them, or if you combine it with anti-PD-1. Symptoms tend to develop within the first 7 weeks, and it's just the typical meningitis symptoms of headache, neck stiffness, photophobia, low-grade fevers, nausea, but the mental status is often fairly normal. When these patients are tapped, the CSF is often with negative culture and cytology, has a little bit of elevated protein and elevated cell count, which tends to be lymphocytic predominant. And but the recommendation is, if they're presenting with a meningitis type picture, they have to be tapped every single time to make sure this is not an infection and this is not leptomeningeal mets. And typical of like any type of meningitis, meningeal enhancement is often seen on MRI. And this tends to be very responsive to oral steroids. The recommended dose is like 0.5 to 1 milligram per kilogram per day. The time course of treatment varies. Like I've seen some reports that said they only did this for like 3 to 5 days, and some other reports that like had to go on for 2 weeks. I don't know if that's just like the patient kept having a headache. But again, this is kind of the tough part about it when we don't have like standard trials to figure out what is the best course of management. Hypophysitis is kind of unique to immune checkpoint inhibitors. So again, patient would present with headache, fatigue, weakness. And the incidence kind of in one review article that I read was estimated at like 3.2% with ipilimumab, 6.4% in combination therapy. And it's, again, the CNS stuff is associated with those CTLA-4 agents. It's very rarely seen with the anti-PD-1 or PD-L1 therapies. The suspected pathogenesis of that there is some CTLA-4 like kind of targets on the pituitary gland, and it just ends up directly targeting those. To be able to diagnose this, and just you need to check hormonal levels. And if there's an evidence of pan-hypopit on your lab work, then pretty much the patient has hypophysitis. MRI brain can show some swelling and enhancement of the pituitary glands. Steroids are just not going to do anything for this. This is kind of irreversible pituitary damage, unfortunately. But the treatment is often feasible, which is just replacing all of the hormones that are affected. And it's helpful in this case just to have endocrinology on board. I read like some of these cases where neurology initially gets involved because of the headache, the fatigue, and the weakness, and just pretty much like endo takes over from there. And for these cases, you can actually resume like the immune checkpoint inhibitor therapy once all of the hormonal deficiencies have been corrected. So it's not kind of a contraindication to resume the therapy, like some of the other presentations that I discussed earlier. Encephalitis has also been reported, although very rare. The incidence is like 0.1 to 0.2%, and it really is a diagnosis of exclusion. Symptoms can be really anything. It can be things that are very, very mild initially, just some fatigue, some syncope, kind of brief episodes of confusion, which makes it hard to tell if like, you know, very tired cancer patient versus like something bad is about to happen. It is a very challenging diagnosis of immune checkpoint inhibitor related encephalitis because the symptoms kind of non-specific and variable. A lot of things have been reported, ranging from just some altered mental status, confusion, some short-term memory impairment, agitation, but they can be as severe as aphasia and seizures. Sometimes these patients can have some like low-grade fevers, and sometimes they can have focal neurodeficits, which some reports said maybe some difficulty standing, some gait changes, but really the majority of reports was this encephalitis. It's just kind of this like very non-specific executive and cognitive function impairment. Again, do the typical workup of a brain MRI to exclude any parenchymal or leptomeningeal mets. An EEG is going to be helpful in this case to rule out some clinical seizures. And then the CSF studies are helpful to, again, exclude the mets or the infections. But in the case of this ICI-related encephalitis, you can have some slightly elevated protein and cell count, but a lot of the times it's just bland. Some report that I read, they said they found some CSF-specific oligoclonal bands, but again, it's a very non-specific test. For these patients, it's helpful to kind of do a medication review, just check their electrolytes, thyroid function, all of those, just to make sure that that's what we're doing at. And there has been some kind of rare reports of the immune checkpoint inhibitors activating paraneoplastic or autoimmune antibodies. So these panels would be helpful to draw specific antibodies that have been associated, like anti-WHO, Casper2, GAD, and MDA. Then given that the presentation is really non-specific, I think some of the recommendation is to start empirical antiviral treatment until you rule out any viral encephalitis, which is very reasonable. These are sick patients with essentially zero immune system. And again, the treatment is going to be to stop the ICI and start steroids really early. These patients often progress to like rituximab though. Sometimes like IVIG and Flex might not do the trick, and they might need like long-term immunotherapy. CNS demyelination has also been reported with ICI. So optic neuritis, transverse myelitis, acute tumefactive demyelinating inflammatory lesions, these have all been reported. In patients who have MS and receive these drugs, exacerbation of their MS has been reported in a couple of case studies. In a retrospective study of the FDA adverse event reporting system, there were at least like 14 patients who reported to have MS flares while on immune checkpoint inhibitor therapy. 8 of those were known to have MS already. Some of them, I think, kind of based on imaging, they just presented for the first time with MS. And 4 of those were already receiving the DMT. Management, again, is going to be stop the ICI, start hard dose steroids. But some of these patients just do not have good responses, and their MS ends up getting like very rapidly progressive. And then they just stop responding to any DMT, which is a little bit unfortunate. And then other neurotoxicities that have been reported, press, I think, kind of comment anything that affects the immune system, and some cerebrovascular events, strokes, giant cell arteritis. I think I read like 1 or 2 reports that mentioned that. So with this, I'm just gonna switch gears now to CAR-T. So CAR-T is really, really cool. The first time I learned about it, it's essentially, you take out the patient's T cells, you collect them, you kind of genetically modify them a little bit with this CAR transgene. You kind of then propagate them, create more of these cells, and then give them back to the patient after some preconditioning therapy with fludarabine and cyclophosphamide. So essentially, you're taking out the patient's T cells and programming them to attack cells. That CAR, the CAR transgene that you added to the T cells, is going to bind to the cancer surface antigen and initiate killing of all malignant cells. It's often used for like as a very last resort treatment of very aggressive lymphomas, and patients have rebounded back from lymphoma really greatly on CAR-T. But it comes with like really severe side effects. So the first one is the cytokine release syndrome, the CRS. I think of this as just like being medically sick. Like these patients are gonna be febrile, hypotensive, they have all of this vascular leak. They're just really, really ill when they have the cytokine release syndrome. The other thing is like being brain sick, which is the neurotoxicity specific to CAR T, kind of known in the literature as ICANS, stands for immune effector cell-associated neurotoxicity syndrome. This can be anything from like a very mild delirium to tremors to global aphasia, seizure, optimization, and can be fatal in some cases. It's bad news, and it's just very difficult to control. And a lot of the times, ICANS is really easy to recognize. Like that's kind of down that rabbit hole that we're going down in, because it is very stereotypical progression. The patient, I remember the first CAR T, actually the second one that I saw, I think we saw them on consults on like a Saturday morning. He was just like kind of slightly confused, and by the evening he was in the neuro ICU. It just starts with kind of this like very mild delirium. The aphasia falls within a couple of hours, and then like essentially status within like maybe 6 or 7 hours after. And it's really limited to like the first 30 days after you infuse the CAR T cells. It's really rare for ICANS to happen any point after that. So with that, again, I'd like to kind of present another case. This case is Mr. T. Mr. T is a 54-year-old man with diffuse large B-cell lymphoma. He was previously treated with 2 courses of chemo and even had a stem cell transplant and had recurrence 3 years later. He was found to be candidate for CAR T and received the treatment. So within 48 hours after initiation, he started becoming very febrile at 39.6. So antibiotics were started. The fever continued despite some Tylenol, and then he became tachycardic to the 130s, severely hypotensive, and he had increased oxygen requirement. And at that point, the OM team felt that he fulfilled criteria for grade 2 cytokine release syndrome. Mental status then began deteriorating with some mild disorientation for time, and he had like a really mild headache. At that time, they did an ICE score, which I will talk about later, and it was found to be 10. Given that he was having cytokine release syndrome, he received the standard treatment for it, which is tocilizumab, and he had quick resolution of that. But the mental status changes kind of stayed there, being relatively mild still. He continued to do well, but then within 2 days, he started having this perseveration and kind of stuttering speech. His bilateral upper extremities were tremulous. He was inattentive, and he was kind of mildly lethargic. At that point, the ICE score dropped to 6. And based on the kind of the grading criteria that I will go over, he was estimated to be at a grade 2 ICANS. He got a brain MRI, which is normal. He was put on EEG that showed no seizures. And then within 2 hours still, however, he progressed to just being completely nonverbal while awake. And ICE score at that time was 0. So essentially, the higher the score, the better. 0 is just, that's the worst score that you can get. He was started on dexamethasone, 10 milligrams, but continued to decline. I got another bolus of Dex 20, followed by 10Q6. An LP was done. He had normal opening pressures, cell count, the PCR panel was negative. He has just a slightly elevated protein. A day later, he was actually a little bit more alert, but still had this global aphasia. And at that point, he had like a mild myoclonus. EEG at that time showed that he had left-sided rhythmic delta, and he had some AEDs that were escalated. I say escalated because a lot of these patients start on like prophylactic kind of baby dose of Keppra when they get in CAR T. But the next morning, he actually had some improvement. His ICE score now kind of got up from that last 0 to 8. Steroids then were tapered over the next 2 days. Over the next 4 days, he still had some mild word finding difficulty, some confusion and tremor, but actually now is ambulating unassisted. And by day 12, he's just completely back to his baseline. So that would be kind of an expected time course for a patient that has the ICANS of CAR T. So what is ICANS? ICANS is if the patient received CAR T, there's a really essentially coin toss chance that they're going to develop CAR T. But it's very specific to CD19 specific CAR T cells. it often follows the cytokine release syndrome. So after infusion, these patients tend to have this like fever, myalgia, rigors, fatigue, and with severe cases, they can have the hypotension, vascular leak, and multi-organ failure. And this is usually easily reversible. Like the standard treatment for it is tocilizumab. The interleukin-6 blockade helps a little bit with the cytokine storm that's going on. And sometimes patients receive steroids in severe cases. But usually within like a couple of days of having the cytokine release syndrome, the patients start having the ICANS, which can present as this like global toxic encephalopathy. Initially some confusion, some tremor. The big hallmark of it really is going to be the aphasias. These patients have like a lot, like start with just some mild work finding difficulty, but can fastly, like really rapidly progress to just this global aphasia. In kind of severe cases, like I mentioned, seizures, depressed level of consciousness, motor weakness, and I've seen like one case where the patient actually ended up passing. They have like really bad cerebral edema. Initially, kind of as I said, mild, kind of waxing and waning mentation, some attention deficits, that stuttering, hesitant speech, and they tend to have like some difficulty with multi-step command, usually associated with like a receptive component of aphasia. Like I mentioned, aphasia is kind of the hallmark symptoms of this. Can be mild issues, but kind of rapidly progressive. EEG is often kind of needed on these patients once they start showing signs of ICANS, because they are really prone to be in non-convulsive status epilepticus. I think I remember there was one patient my JAR year who was in the neuro ICU in like status for like 20-something days. And it's really difficult to break the status sometimes. The EEG, however, if they're not in status, can a lot of times show this kind of diffuse slowing in the theta to delta range with some frontal rhythmic delta. And that's kind of what they expected some of these patients if they're not seizing. So how do you grade ICANS? Because I think that was one of the things where the oncology team called us saying, I think I have a patient who was grade something ICANS and wants your help. And I think it's helpful to know what this grading system is, because it would essentially know kind of where your patient is at, and then determining what do we need. Like, do we need to call the neuro ICU to make sure that they have the bed, because I think this is a patient who's really close to the cerebral edema, or is this somebody who's okay just hanging out on the floor while kind of we're managing seizures or things like that. So the first thing that the first component of the grading of the ICANS is the ICE score. So this stands for Immune Effector Cell Associated Encephalopathy score, and it's a 10-point scoring system. It really is a kind of like pared down mini mental status exam. It focuses on like CAR-T encephalopathy specific domains. So the patient is asked some orientation questions, the year, month, city, and hospital name, which gets them up to 4 points. They are asked to name 3 objects. They're asked to follow commands, and all what they need is just to follow one single command. It's just 1 point. And then writing, they're asked to just write this standard, like grammatically correct sentence. And then attention, they're just asked to even do serial 10s from 100. So it's not meant to be tricky. It's just, is the patient like fully with it or not? If they're able to do all of these tasks correctly, it's 10 points, no impairment. 7 to 9 is like grade 1, 3 to 6, grade 2, 0 to 2, grade 3. And 0 is kind of patient is unarousable or unable to form any assessments. That's grade 4. But that is kind of like the first component of the grading, and it gets a little bit confusing. So you're grading the patient on different domains. One of them to get an overall grade. So one of them is this ICE score. You're grading them in their overall level of consciousness, if they're having seizures, any motor weakness, and any assessments that can indicate that they're having elevated intracranial pressure. And then whatever they score in the highest in any of these domains is their final grade. So, if their ICE grade is 2, but for some reason their motor grade is like 4, then they are grade 4. And this is what they're looking for. So the encephalopathy component is the ICE 4. And by grade 4, you're just looking at a patient that's going to have life-threatening consequences, and urgent intervention is like indicated now. Seizures, They can range from just kind of brief partial seizures with no loss of consciousness to essentially the patient is in status at grade 4. And then dysphagia, again, the hallmark of it, this actually goes up all the way to grade 3. Tremor is another thing that is common to these patients. And again, it just comes down to, is it just a mild tremor and is it affecting self-care ADLs or not? Headache is another one, goes up to grade 3. Confusion is another one, and essentially just like how oriented the patient is. And then level of consciousness is again, like if the patient just kind of alert every here or there, but easily arousable versus like the patient essentially is comatose. And then same thing, cerebral edema automatically starts at grade 3. I don't think there's a way to downplay beyond that. But really just kind of when we are asked to evaluate these patients, I think we should just like look at all of these different things. The recommendations that I've seen is like anything grade 3 or higher, these patients should be in ICU level care because that means like grade 4 is just impending soon. That also means that these patients need a lot of frequent kind of reassessment and neuro exams because the exam, like I mentioned, can change within hours. So when we're being consulted about these patients, it's helpful to kind of know like what is the baseline, and don't be surprised if you're like by the team within like 2 to 3 hours to say, okay, you know what, they're starting to have this symptom now or here. And some of them can be very subtle symptoms, but if the tremors are worsening or the level of consciousness is getting worse or the aphasia is getting worse, I think again, like I said, it's a very low threshold to have these patients in an ICU level setting. ICANS is interesting because even though it's kind of the big thing, the big bad thing associated with CAR T, we really don't know what is its pathophysiology, which makes management a little bit difficult. There are some reports that say the cytokine and the chemokine elevations and the degree of the CAR T cell expressions have been linked to the degree of neurotoxicity. But typical treatments that you use for the cytokine release syndrome, like tocilizumab, have not been shown to be that effective specifically for the ICANS and neurotoxicity, even though there's some suspicion that it's really the cytokine and the chemokine. There's like one study that I saw that mentioned that actually when patients receive tocilizumab, they tend to have slightly higher rates of ICANS. So a little bit tricky here to figure out kind of what is causing it. There are some studies where they sampled the CSF of these patients who received CAR T cells, and they found that these cells are often found in the CSF. So they have good CNS penetration, but the amount of cells did not necessarily correlate with the degree of the toxicity. And some patients who don't even develop neurotoxicity can have actually a good number of these CAR T cells in their CSF. So a little bit tough to tell if it's really kind of CNS penetration or not. Another theory is there's some endothelial cell activation and kind of this blood CSF barrier destruction is associated with a degree of neurotoxicity. And then there's possibly maybe a potential role for myeloid cell activation in the CNS. In some studies, when patients had ICANS and they tested them for their levels of glutamate and quinolonic acid, some elevations were observed, and they associated that maybe this is related to seizures, given that these are excitatory neurotransmitters. And then there were some studies that showed that there might be some role for interleukin-1 in its pathogenesis, and maybe potentially trying like anakinra, which is an interleukin-1 blocking agent for these patients. And I think this is actually being explored right now in a clinical trial. So because we don't know what it is, how do you manage it? And the answer is simply, honestly, sadly, just supportive care. The OM team usually has this protocol of starting steroids, and they truly try to reserve that for very severe grades. And the reason why is that steroids essentially negate the action of the CAR T cells. So by starting them, you're less likely to have a good response from the cancer treatment itself. A lot of these patients are started on prophylactic Petra, so starting day one, or any other AD of choice, but usually here I think they do to start on Petra, and this has to start beginning day one of the infusion. The good news is if the patient survives this, it tends to be self-limited and very irreversible in those patients, but they really need a lot of supportive care to get them there. And the big thing is that we don't know if there's any kind of long-term neurological consequences from this, like if these patients are going to be more prone for dementias or other issues down the line. I think we're kind of need more data to learn about this. Other neurotoxicities that have been associated with kind of CAR-T specifically, PRES is often seen, but I think in the grand scheme of things, compared to ICANN, there's really not that much in terms of management and supporting the patient. And although tremors and myoclonus can be seen in the setting of ICANN, it can be just an isolated thing. And it's usually, if it's just an isolated thing, it's very mild and relatively transient. I think like the estimates that I've seen, maybe like by day 10 after infusion, it's usually resolved. And simply my conclusions are, I mean, immune checkpoint inhibitors, they can have some very severe and fatal complications. The IDP can lead to like respiratory issues, same with the myositis. And like I said, there's a 30% chance of death when these patients get myasthenia gravis from respiratory failure, because 40% of them would end up needing a vent. But the treatment is just very standard: steroids, IV-Agirplex, and then rituximab or some long-term immunomodulation, and kind of seeing how the course goes. And ICANS is kind of like the big bad with CAR-T. It can often lead to death, and just like need to be on the lookout for it. Treatment is often supportive care, and just sometimes these patients just need an ICU setting. But these cancer immunotherapies are here to stay. And I think, as neurologists, we should be very familiar with their complications, because I think we're just going to keep seeing more and more of them. More immune checkpoint inhibitors are being developed, and we can already tell that there's like a preference for like the PD-1, PD-L1 group for the peripheral nervous system, the CTLA4 group for the central nervous system. I don't know if there will be like a new category soon, but also like I was reading some case reports that they're exploring the role of like immune checkpoint inhibitors for things like PML. So these agents are just going to be around, and we really need to kind of predict like how to support these patients the best and how to manage them long term, because just they're not going away. These are my sources. Just quick thank yous. Just want to thank my fiance Teddy, who's been great support throughout residency, and a shout out to our fur baby, Meek Millie, who makes going home after a long day at work very much fun. You can follow her on her Instagram handle. I just want to thank my family and friends again for being like a huge support throughout these like past 4 years of residency. And I'm really looking forward to making a new trip with everyone here for the Grand Canyon. Just shout out to all of the attendings and the program leadership, Dr. Eckstein, like worked with all of these years. I am who I am today because of all of your help and education. And a special shout out to Suma Shah for being the most awesome mentors. And last, to all of my co-residents, past and present. And that's it for me.
Thank you, Petra. Yeah. So in the interest of, there are some good references in the chat too. In the interest of time, if anyone has questions for Petra, just send her an email and CC on it too. But great job, Petra. And we'll see you soon, and stay safe. Bye, everybody.